Sorry, sir. Hello.
Carry on, nothing.
Yeah. So, cerebral vasospasm is mostly focal, but sometimes diffuse, reversible constriction of intracranial arteries. And why we need to know about it is basically, a recognized form of secondary brain injury, and it has potential to cause ischemia and infarcts in the brain. That is why we fear about vasospasm. And the problem is we associate vasospasm with aneurysmal subarachnoid hemorrhage, although it happens in many clinical scenarios, but we more associate it with aneurysmal subarachnoid hemorrhage. Now, to spot it, we have TCD. TCD is common bedside, radiological modality which we do at the bedside. And as I told, the common causes of vasospasm is based from that. Even if a subarachnoid hemorrhage happens in case of trauma, even if it is an intracerebral hemorrhage, ruptured AV malformation, we get to see vasospasm. Also, an important cause is acute bacterial meningitis, also a postoperative complication of intracranial tumor surgeries. Very rarely, iatrogenically, we can induce vasospasm, say, when we push IV contrast or catheter guide wires during neuro interventions. Sometimes it may happen iatrogenically also. So, what exactly happens? Why does vasospasm happens? The pathology is, so the hemoglobin, because there is a spill of blood in the cisterns, there is a hemoglobin to it, and then that hemoglobin causes endothelial damage, cytokine release, and free radical generation. Once any inflammation starts, platelets come in, they aggregate, they release even more vasoactive substances. And when there is a lot of inflammation, there is actually a excess influx of calcium into intracellular compartment that induces a strong contractile response. Added to this, there is a decreased nitric oxide production and increased endothelial 1 production, basically because of endothelial damage. Not just inflammation, there is also adrenergic nerve fibers that get stimulated. So that also adds to the vasoconstriction of the blood vessels. And if all of these processes are sustained, then we see a structural changes in the blood vessels, which is a cause of delayed vasospasm. So then it is more of a vasculitis delayed vasospasm phenomena. So this is the basic pathophysiology of how cerebral vasospasm happens following aneurysmal subarachnoid hemorrhage or any blood spill. The parallel to this is that in acute bacterial meningitis, the bacterial exudates, they form in the base of the brain. So whenever there is a bacterial exudates, so that bacterial exudates irritates blood vessels in form of endothelial damage, cytokine release. So bacterial meningitis, by virtue of producing exudates near the blood vessels, they cause vasospasm. So now, as we discussed, to diagnose vasospasm, we have transcranial Doppler. You can see this first image is basically a vasospasm seen with transcranial color-coded duplex sonography. This is a CT angiography, and this is MR angio of sequence. DSA is also done. It's a gold standard procedure to diagnose vasospasm. But as we climb ladder, first is transcranial Doppler. Once we get suspicious on transcranial Doppler, we most often go with CT angio and then followed by DSA. And when vasospasm happens, usually we go ahead with initially medical management. So that medical management includes enteral nimodipine, both as a prophylaxis as well as treatment of vasospasm. We go ahead with intraarterial nimodipine or calcium channel blockers, especially if we have severe vasospasm, moderate to severe vasospasm, threatening any ischemia or infarcts. Intravenous and intraarterial milrinone. and we go for augmentation of hemodynamics. These are routinely done medical management for vasospasm. Other than that, there are other therapeutics as well, like we use nicardipine, verapamil in various ways. They tried intrathecal modality, they've tried intracistern placement of nicardipine, cilostazole, clazosenatan, fasudel, magnesium. These are all other therapeutics, but then the commonly what we use is nimodipine, belrenone, and augmentation of hemodynamics. So, what actually happens, to hemodynamics, to the intracranial cerebral arteries which undergo vasospasm is that, so whenever there is a vasospasm, there is a decrease in vessel diameter, which leads to increase in velocities. It follows Bernoulli's principle. Now, what happens is whenever there is a mild narrowing, it doesn't influence any flows. So we rarely get to see any disturbances in transcranial Doppler. But whenever there is a moderate narrowing and severe narrowing, definitely we get to see flow disturbances in the transcranial Doppler. How do we see is that so flows are increased. So whenever the vessel diameter decreases, velocities increase, and we are taking velocities and flow as a a comparator to each other. So we actually measure velocities rather than flow in the transcranial Doppler. So flows are managed as long as cerebral autoregulation is intact and blood pressures are above the lower limit of autoregulation. So at this point of time, the flows will increase, and you can see that velocities are also increased. But whenever there is a severe narrowing, severe vasospasm is there, it behaves like a critical stenosis. The more the narrowing is there, the blood flow starts decreasing. So this we I think we have learned in the last class, Reed-Spencer curve. So what we need to understand is that the criteria of velocities to diagnose vasospasm alone is not sufficient. Why? We'll look into the next slide. So this we have taken from Rune Asled's paper. So Rune Asled is father of transcranial Doppler, and one of the first applications of neurosonology or transcranial Doppler is basically to look at the vasospasm. So in his era, people were doing a lot of CT angios. Angiographies basically they do, and then that is where they used to look at vasospasm. So then Rune Asled has actually looked at how transcranial Doppler velocities are, and he compared it with the angiographic appearance of vasospasm. So here you can see that there are two things. One is a velocity, one is a volume flow, and on the x-axis we have lumen diameter. So they say that MCI's diameter is 3 mm, and as you see that as the lumen diameter decreases, you can see that the velocities have increased, but to a certain point, the flows have remained stable. And when there is a critical stenosis, say that this is the point of critical stenosis, the velocities have started coming down, the flows have started coming down. And that is why we need to understand that velocities alone may not be able to tell us accurately what is happening about the blood flow. This is because of this study we got to know. And also they have mentioned how augmentation of hemodynamics help. Like for example, we can see that as the lumen is narrowing, when the arterial blood pressure is at 100 mmHg, you can see that there is much more dip in the volume flow. Whereas at 140, the volume loss at critical stenosis point is comparatively less. This so similar thing with the velocities. So the takeaway point is that, so although we relate velocities to the flow in transcranial Doppler, this is a bit kind of an outlier where to a certain point velocities and flow do not match. So that is why to take velocities alone for the diagnosis of vasospasm is not an accurate method. For the same reason, Rune Asled has identified a ratio which is later popularized as Lindegard ratio. So what he found is he wanted to see the velocities inside the brain and the velocities in the arteries which is supplying to the brain. So basically intracranial flow and extracranial flow. And he wanted to take a ratio. And he tried looking at that ratio and how is it getting the vasospasm. So then they found that this ratio is a much better criteria to diagnose and categorize severity of vasospasm than the velocities alone. So that is where we come in some time about the linear artery issues and all. But so now we know how hemodynamics are altered during vasospasm. Now we will know how we use transcranial Doppler for the assessment of vasospasm. So the first thing we need to understand is you need to have an appropriate clinical situation. So appropriate clinical situation is where you have to keep in mind the causes of vasospasm. So you need to understand that apart from aneurysmal SAH, even in traumatic SAH, ICH, then even in acute bacterial meningitis, when the radiological say that you have got a NCCT head and it is not explaining the worsening, neuro worsening, what we do is in the second place, we look at the transcranial Doppler to see the flows and identify, any vascular causes as a cause of deterioration. So sometimes we get vasospasm, sometimes we get, stroke. So that is why we need to understand that, looking for vasospasm in an appropriate clinical situation improves the value of TCD. So first is appropriate clinical situation, aneurysmal SH, traumatic SH, ICH, acute bacterial meningitis, what we see routinely. After that, once you get a case of any of these clinical scenarios, try to establish baseline value as early as possible. Say that you get an aneurysmal SH case post-coiling, try to do a transcranial Doppler bilateral vessels and try to establish the baseline values. Then you can use this baseline value and then try to see how they are faring up in consecutive days. So they say that in the initial surveillance period, say if vasospasm starts from day 3 to 5 and it peaks at 7 to 14 days. So they say that start from the day 3, and when you start, depending on the clinical scenario and the velocities, you do once daily or twice daily TCD monitor, document all the velocities, and when you do it, while you are insunating a vessel, say that you are insunating the middle cerebral artery. So our habit is to just insunate, at one point of middle cerebral artery, we know velocities, we say there is no vasospasm. Okay. But the trick is that we need to sequentially, measure velocities of a blood vessel, either from proximal to distal or distal to proximal, because the sequential insunating of a vessel is important, which we call it as traceability. It is important because many a times vasospasm is a focal phenomena. So if you just measure at one point, you are likely to miss, vasospasm at a place where it is actually happening. Okay. So what ideally we do is at least we measure, at least 4 points, in the entire proximal MCA course. So traceability is something very important. Otherwise, there are more chances that, we miss vasospasm. And when you are measuring sequentially the velocities from proximal to distal or distal to proximal, usually the point at which you get highest mean flow velocities is the point of vasospasm. And in our clinical practice, we have accurately pointed out where the vasospasm is. So most of the time, if you pick up the highest mean flow velocities using traceability, you are more likely to actually locate the vasospasm, and it corresponds to the location of vasospasm in the DS as well. Okay, so next is whenever you are insunating intracranial vessels, never ever forget to insunate extracranial vessels to measure the ratios. Also, most importantly, whenever you are measuring these velocities, always consider hemodynamics and PaCO2. As you have noticed that augmentation of blood pressure actually varies velocities, right? So first is measure intracranial velocities, use traceability, then pick up highest mean flow velocities, you measure velocities in the extracranial vessels also. And as a holistic measure, try to look at the hemodynamics, note down the blood pressure at that particular point of time, as well as POCO2. So with this, I'll just demonstrate like why flexibility is important. So we have started from proximal to distal in MCA. So we can see at this point of time, peak systolic velocity is 158. Now, as I just moved up, the peak systolic velocities have become 337. And just to clear your confusion, the velocities which we use in assessment of vasospasm is mean flow velocities. And just to give you an example, I've just used peak systolic velocities here. So you can see at starting point of proximal MCA, it is 158. Now this is 337 peak systolic velocities. And as I move more distally, you can see, again, the peak systolic velocity is around 127. And, in the distal bifurcation of M1 into M2, you can see that the velocities are normalized. So this example tells you that, most often the vasospasm is a focal phenomena. And why is it important to actually locate vasospasm through, traceability? So, and you can notice that both in the vasospasm, peak systolic velocities increase, end diastolic velocities increase, so mean flow velocities also increase, and that is one reason why we take mean flow velocities as a standard, because it is a bit less influenced by the hemodynamics. Whereas if you take peak systolic and end diastolic, they are much more influenced by other parameters. And suppose we need to have a starting point, right? Like, so when to suspect criteria to either suspect or diagnose vasospasm based on velocities. So the first and the most common location is basically middle cerebral artery. So we can start suspecting vasospasm whenever there is a mean flow velocity more than 120 centimeters per second. And when we do a daily measurements, increments of 35 to 50 centimeters per second, it predicts severity. And more often, mean flow velocity is more than 200 centimeters per second, predicts moderate to severe vasospasm in MCA. And if we see anterior cerebral artery, there is a cutoff for diagnosis. Mean flow velocity is more than 130 centimeters per second. Posterior cerebral artery, more than 110 centimeters per second. Vertebral artery, it is more than 80 centimeters per second, and basilar artery, 70 to 85 centimeters per second. So not peak systolic velocity, but whenever you see mean flow velocities crossing a certain limit, so then we need to understand that either there is a hyperemia that is happening or a vasospasm is happening. So in order to differentiate both, we need to look at velocity ratios. So, the first and most famous one is Lindegard ratio. But there are two other ratios for anterior cerebral artery as well as basilar vasospasm. So the first one is Lindegard ratio. What we do is we do a transtemporal transcranial Doppler. We pick up mean flow velocities of middle cerebral artery. Then we insonate a submandibular window, and we get extracranial portion of internal carotid artery. So we divide those mean flow velocities, and if the score is more than 3, it is vasospasm. Less than 3, it is hyperemia. And if it is 3 to 6, it indicates mild to moderate vasospasm. And score of more than 6 indicates severe vasospasm. So this is the original description of the score, but it has been modified, for some various unknown reasons. Some say 3 to 4 is mild, up to 5 is moderate, and maybe more than 6 is severe. But this is the original description where they say score of 3 to 6 is mild to moderate vasospasm, and more than 6 is a severe vasospasm. Now, in order to do for anterior cerebral artery, what you do is, again, you get a transtemporal window, insonate anterior cerebral artery, A1, or wherever the vasospasm is, A1, A2. You pick up the mean flow velocities of anterior cerebral artery. Then again, you do the same submandibular window, pick up extracranial portion of internal carotid artery. You divide them. Score of more than 4 indicates vasospasm. And one tricky part of looking at anterior cerebral artery is that now two anterior cerebral arteries, right and left, they are connected with ACOM. So whenever a vasospasm happens, so more or less it gets diverted to the other side, and the chances of you picking up a vasospasm is comparatively less than a middle cerebral artery because of ACOM. So posterior circulation does have vasospasm. More often happens in the basilar artery. So in order to look at vasospasm for basilar artery, we see Sostiel ratio. There's some confusion regarding Sostiel ratio and Swiri ratio. Both are the same. Sostiel is the first one who started looking at vasospasm in the posterior circulation, and Swiri is the one who has actually validated it. So Swiri, out of respect, in his paper has told that it's better be a Sostiel ratio rather than a Swiri ratio. But then there is some misinterpretation of the literature. You find both Sostiel ratio and Swiri ratio in the literature, but it's actually the Sostiel ratio. What we do is you insunate through transforaminal window a basilar artery. You pick up the mean flow velocities, the highest one, and then you keep the probe at mastoid process and try to get extracranial vertebral artery. You pick up the mean flow velocity, and score of more than 3, it indicates severe vasospasm. So the same paper by Swiri, I'm showing it here. So this is the paper by Swiri where he validated Sostiel's finding. So here he categorized if the ratio is more than 2, it is vasospasm. If it is more than 2.5, it is moderate or severe vasospasm, but more than 3, it is severe vasospasm. So here the cutoffs he has given is more than 70 and more than 85, for vasospasm and severe vasospasm. So as I told, like Lindegaard ratio, how do we calculate? This is the transtemporal window. This is MCA, ACA. Now I place my, so I have insunated MCA, proximal MCA, and I got this waveform. And you can see that TA max, which is mean flow velocity, is 235. So 235 is the mean flow velocity of MCA. Next, I've taken a submandibular window and using the same probe. So I've used a phased array probe for insunating a transtemporal window, and I'm using the same window, same probe for insunating extracranial internal carotid artery submandibular window. Now the trick is that so if you may ask, sir, why don't we use linear probe? So usually what happens is linear probe has an angle correction if you use a artery, if you use a artery preset. So whereas when you use a phased array probe, you may or may not choose a angle correction. So it is said that if you have not done angle correction in one method, it's better you don't do angle correction at another method. So that is why it is important for us to use a phased array probe and insunate submandibular window so that we don't do angle correction in the in the measurement of extracranial internal carotid artery. And the second reason is that if you use a say linear probe, we will be we'll be able to see what is called as external carotid common carotid artery, carotid bulb, and bifurcation into external carotid artery and internal carotid artery. Beyond that, we may not be able to visualize. Whereas what the literature says is you need to measure the velocities as near as possible to the intracranial circulation. That would be more valid. So here in the diagram, you can see that using a phased array probe, and you need to insulate extracranial internal carotid artery at around 50 mm depth. Okay, so 5 centimeters, 50 mm depth. That is where you need to insunate your extracranial internal carotid artery. That is where the comparisons are made, and the comparisons would be accurate. So you might see some people doing a linear probe at the carotid artery. That is not an accurate method to measure Lindegaard ratio. Always use a phased array probe. So this is basically a differential of vasospasm, where you can see that by the way, here you have a TM max of 41, and here we have a TM max of 235. So 235 divided by 41, it is coming around more than 5, and so this fits into a moderate vasospasm. Whereas, so this is the differential of vasospasm. The differential is hyperemia, where there is loss of cerebral autoregulation and brain gets a lot of blood flow. So here you can see that TMAX is 133, and because it has crossed more than 120 centimeters per second in MCA, I've looked in the submandibular window, and in the submandibular window, I have seen that TMAX is 81. Now 120, 120 divided by 80. Okay, so the ratio is less, and it more likely is a hyperemia. And the Sostiel ratio. So Sostiel ratio, here you can see that I have insulated transforaminal window, and I've insulated a basilar artery. The velocities are TM max is 101. So as per velocity criteria, it goes into severe, but we need to look at the ratios. And I'm the one who said that you need to use a phased array probe, and I'm the one who is breaking the rule. So because I'm unable to insunate vertebral arteries extracranially with a phased array probe, I've chosen it as an alternative to to insunate vertebral artery extracranial using a linear probe. Maybe I'll learn soon. And the TMAX here I have recorded is 31. And you can see that angle correction mode is on and angle correction is 60, whereas here angle correction is not there. So maybe there might be some difference in measurement of velocities. Uh, I've just taken it for granted. But then it's important for us to use a phased array probe to actually measure extracranial vessels. So now, why do many people oppose transcranial Doppler? If you see Critical Care Medicine Journal, you get articles saying that the era of transcranial Doppler for vasospasm is gone. Why do they say? So they say because apart from middle cerebral artery, the sensitivity and specificity for other circulations like anterior cerebral artery and posterior cerebral circulation is less. Okay, so AC is tricky because there is flow diversion through ACOM, whereas in posterior circulation it is difficult because a lot of anatomical variations of blood vessels, you see it in the posterior circulation, and because of such anomalies, it is very tricky to actually identify accurate velocities. And all we talk is about proximal vasospasm in the proximal arteries. More often, distal vasospasm is missed. And so these sensitivities are basically for the middle cerebral artery, it goes up to 81%, and specificity goes up to 96%. Positive predictive value is 98, and negative predictive value is 69. So what it essentially means is that if you just identify one point and say that velocities are normal, no vasospasm, you are more likely to miss. So that is why sensitivity is a kind of less. So and more importantly, a lot of trials have been done apart from nimodipine, many other therapeutics which are targeted to manage vasospasm. They have not translated to better outcomes. So they have not improved mortality. They have not improved DCI, delayed cerebral ischemia outcomes. So that is why they feel nowadays, vasospasm is not, the game changer. But still, if it is severe enough, it actually causes ischemia and infarcts, which is terrible. So, this is one paper, interesting one, which says that so people used to think previously that delayed cerebral ischemia, vasospasm is the main cause. But later on, they understood that, because treating vasospasm is not translating outcomes into DCA improvement. So they understood that some other phenomena might be playing here. So that some other phenomena is basically microthrombosis in the vasculature, and another one is cortical spreading depolarizations. Okay, so these two are another set of phenomena which drives delayed cerebral ischemia. So this paper has seen the distribution of infarcts among patients who had delayed cerebral ischemia infarction after aneurysmal SH. So what they found is it is not uniform. So it is not territorial. It is sometimes partial territorial, full territorial. I mean, the vascular territorial. There is sulcal, deep, multifocal, and cerebellar. So what they have found is at least 44% are partial territorial infarcts and 12% are full territorial infarcts. This partial and full territorial infarcts, almost amounting up to 50%, says that this kind of infarction is basically attributed to vasospasm. So you can say that still a major part of DCA is driven by vasospasm. So it is essential for us to not miss vasospasm in aneurysmal SH. So what does guidelines say? Okay, so what does guidelines say? This is about AHA and American Stroke Association guideline, which has come in 2023. What it says that there is a two-way guideline. I mean, like recommendation for using transcranial Doppler. They say that it is reasonable to detect vasospasm and predict DCA. Okay, so we have a backup from guidelines also that there is a two-way recommendation to use a transcranial Doppler, not just in detecting vasospasm but also predicting DCA. Velocities do not predict DCA. Ratios predict DCA in a much better way. Now, my curiosity lies in traumatic brain injury and vasospasm after it. So we have come across a young male, 25-year-old male, and under alcohol influence, he had a road traffic accident. There is a left-sided SDH. Initially his GCS is good, but so they have not operated that SDH. I think on day 6, patient was operated for decompressive craniectomy because there's a dip in GCS. So then, immediately post-operative, day 1, he was fully conscious, M6, no deficits. He has been extubated. So day 7, day 8, he started having a deteriorating GCS. Then it progressed to have focal seizures on the right side, and by the time we have diagnosed vasospasm, he already started to have a hemiparesis in the right side. So what happened is that we have done a CT scan, no extraordinary, space opening lesion or edema or something like that. So that is when we have done a transcranial Doppler. Transcranial Doppler showed, severe vasospasm. It was confirmed with CT angio, and we have taken him to DSA. And in DSA, we have given him intra-arterial nimodipine 1 session. We have got him back. We have treated, like how we have treated aneurysmal SH vasospasm. We have given enteral nimodipine. We have given intravenous milrinone, augmentation of hemodynamics. All of it has been done. So maybe by day 10, day 11 post-operative, day 11 of injury, so he has improved, and there is a hemiparesis has subsided, seizures got controlled, full GCS, extubated, shifted to ward. He was even doing his own work independently. He has come back for cranioplasty as well. So what made a difference is the awareness of vasospasm happening in traumatic brain injury. So to talk about it, the incidence is up to 40%. It most often, associates with traumatic SH. So let me tell you that traumatic SH is the most common cause of SH and is the most common finding in moderate to severe TBI. Okay, so it is associated with traumatic SH, and traumatic SH, whenever it is present with other lesions, gives a bad prognosis. Okay, comparatively bad prognosis in its presence. So associated with traumatic SH can be seen without it as well. Okay, just by having blood in the cisterns, it could be SH, it could be ICH, IVH, or simply SDH. You can simply, without having SH also, you can see vasospasm. More often you see in middle cerebral artery and basilar artery. And onset and duration of vasospasm are variable. But what the literature says is, so there are two sets of ideas. So one thought process is that the onset and duration of vasospasm, when you compare it with aneurysmal SAH, is shorter duration. It occurs early, it is shorter duration. But whenever it is associated with traumatic SAH, moderate to severe brain injury, the onset and duration mimics that of aneurysmal SH. So we need to keep in mind that it is not less severe compared to aneurysmal SH. It is almost at par with aneurysmal SH. So up to 16% develop neurological deficit, although majority they're mild to moderately severe vasospasm, but still in terms of onset and duration, whenever there is a traumatic SH, vasospasm onset and duration are at par with aneurysmal SH. So now we go to acute bacterial meningitis. So we often see that in bacterial meningitis there is increase in velocities. The reason is that in meningitis there are basal exudates, and to my surprise, when I was looking at the literature, different organisms have different predisposition for exudates at different parts in the intracranial. So Haemophilus influenza, they say that involvement of supraclinoid portion of internal carotid artery. Streptococcus pneumoniae, it involves small cerebral intracerebral arteries. And Mycobacterium, it involves basilar arteries. So we often hear that basal exudates is equal to TB meningitis. But you need to understand that exudates are present at other places also, and it's a common finding of acute bacterial meningitis. So how does it translate to meningitis is that so this is one beautiful case shared by Albin, Catherine Albin. So what it says is that now a 59-year-old patient has come to emergency department for altered mental status. On examination, she was found to have a stroke. But when they have done a CT angio, there is not much of large vessel occlusion, questionable right M2 and M3 branches, vascular narrowing. They have not taken it seriously. So then when clinical examination was further done, they found that the patient was tachycardic and normotensive and afebrile, elevated lactates and leukocytosis. So they were surprised, afebrile, but tachycardic, normotensive and all. So, on probing further, what they found is, the patient is suffering from meningococcal meningitis. And when they look back, what they found is, it is basically the meningococcal meningitis that has caused this tachycardia and elevated lactate levels. And that is the reason for stroke she had. So basically what happened is here, there is a vasospasm of right M2 and M3 branches that has resulted in the stroke, where she had right gaze preference, left hemi neglect, and paresis. So this was a result of vasospasm in acute bacterial meningitis. So it has presented as a stroke because of vasospasm. So the takeaway message in this is that meningococcal meningitis can induce focal neurological deficits via direct invasion or induction of cerebrovascular dysfunction via vasospasm or hypercoagulability or direct vascular injury. In this case, it is vasospasm. So what they say is that although moderately sensitive and highly specific to proximal vessel spasm, especially of MCA, TCDs are not sensitive at detecting distal vasospasm that are provoked by infectious meningoencephalitis. So what I want you guys to take this take away from this particular case report is that whenever there is a in meningitis case, whenever there is a change in neurological status, also consider vasospasm as one of the differential diagnoses. Sometimes you find it in proximal vessels, sometimes you find it in distal vessels, but it is good to keep vasospasm as one of the differential diagnoses. Otherwise, we often tend to miss and we'll be like, okay, what is happening? The seizures are not there, and no structural changes are not there. So we'll be beating around the bush if we miss vasospasm. And and to my surprise, this study from O'Brien has surprised me. What they've done is in cerebral malaria, they've used a Lindegard ratio to see whether there is a hypoperfusion or not. So this is a wonderful example which says that you need to look at both sides of the coin. Okay. So here what happened is Lindegard ratio, we often look at one side of coin for hyperperfusion. Okay. So we look for hyperemia, we look for vasospasm. What they have done is they were wondering if the ratio actually reflects a decrease vascular supply. Okay. So that they call it as a cerebral hypoperfusion. And they have repurposed this particular use of Lindegard ratio as brain shock index. Although this study has been done in children and in cerebral malaria, it might be true to various acute bacterial meningitis where hypoperfusion can be a important phenomena. So they've come up with a number. What they say is, if a brain shock index is less than 1.1, less than or equal to 1.1, it correlates with cerebral hypoperfusion and also with poor neurological outcomes in children in cerebral malaria. And this is a wonderful thesis topic for anyone who is into neurocritical care. They can actually look at various bacterial meningitis, TB meningitis, cerebral malaria, or any tropical fevers which presents with cerebral manifestations. We can actually look into this brain shock index and see if there is a cerebral hypoperfusion or not. So this is just repurposing Lindegard ratio, looking at the other side of coin. So this is a new advancement. I found it recently. So I mean, we have talked a lot about vasospasm, but then if you have a deteriorating patient with SH, also look at ventricles. So if you keep a transcranial phased array probe at a transtemporal window and you tilt it up, you get to see ventricles, lateral ventricles. Why is it important? In aneurysmal SH, even hydrocephalus occurs acutely, and it is one of the important causes of neurological deterioration in SH. So I would say if there is a deteriorating patient with SH, address PaCO2 because hypocarbia is deleterious, and both hypocarbia and hypercarbia both are deleterious. And temperature, fever is a important cause for augmenting blood flows, which is not good. There will be a break in cerebral autoregulation. Hyponatremia is bad in SH. Look for hydrocephalus. Be aware of raised ICP and non-compressive status epilepticus. Also, SH is never a cerebral entity. Systemic complications is a rule rather than exception. Sepsis, including meningitis, are major causes of systemic complications. But nevertheless, ARDS and Takotsubo also mess up systemically. And even though we deal with all these things in the early period and we sort out vasospasm tends to occur late in the period. So that becomes a vasculitis problem. It is a bit difficult to treat with the nimodipine and milrinone. So I end my presentation. The key takeaways is always consider vasospasm as one of the differential diagnoses for any neurological deterioration in an appropriate clinical scenario. Use transcranial Doppler. Don't limit yourself with the velocities alone. Go to ratios as well. It's important for us to look at the ratios. And as they say, if you innovate, it's great. So we can use brain shock index for various tropical fevers or neuro infections to find out whether there is a cerebral hypoperfusion or not. So I once again many thanks for Vinay sir for starting this club, and thank you for giving me this opportunity.
Great one, Mohan. So I am very surprised at this photo. This is an extracorporeal circuit. Whether was it VV or VA, both has its own implications on TCD.
I mean, this is where we were looking at, sir. I think we had a recent discussion, right? Also, guidelines do not recommend transcranial Doppler as a modality, neurological monitoring modality. So now, what we are trying to do, there is one more person by name she.
So I think we just lost Mohan because of your connectivity. So one of the queries in the chat box is any relationship between the site of DCI and aneurysmal site. So site of SAH and DCI can be in totally different territories, even including the site of vasospasm. So that is one thing which we need to mind. And the other thing is, as you were telling, South-Tail ratio, or what we call as modified
ratio, the denominator is the average of vertebral artery aneurysms. So it's not just one vertebral artery which we need to take.
I'm
yeah.
so sorry, sir. I lost my
That's,
connection.
that's fine. We just carry on, Mohan. I was just putting.
I mean, sir. Thanks to my colleagues and juniors, and because they are also interested, and we keep doing with them. They also give us good set of suggestions, and also as I told with Vijay Balaji, we started exploring various clinical scenarios, and ultimately our thought process is to bring transcranial Doppler out of neurocritical ICU, make its utility valid in general ICU. So that is where we are trying to go, and I'm happy that we have some common interests, so we can take it together.
And one more query, I think one of the persons in the last discussion was asking about PI. Why is it low in the vasospasm? As you had told, that's one thing. Velocities and PI, what does it reflect is what
resistance distal to the site of insonation. So it doesn't really tell what is at the site. So in vasospasm, as we all know, there could be a distal vasodilatation. So that could be, more of a physiological reasoning why the distal site, why the PI is low in vasospasm, because the site distal to the insonation or the site distal to the vasospastic segment would be normal. So that's one thing. And that's it. I think any other things, any other persons want to comment or something?
Yes, sir. I think maybe say that if there is a distal vasospasm, say that if we track into the distal vascular bed and we find increased I think maybe one of the differential diagnoses apart from raised ICP can also be vasospasm if it happens in the distal bed. So I think maybe that is where it also helps. I think we have one question can focal DCI cause raise in ICP? No, it doesn't cause raise in ICP. Dr. Bartesh.
Yeah, he is my colleague.
Yeah. Oh, sir, I'm so sorry.
No, I find no issues. So that's it. I think it was good discussion. So we'll come up with, since the last image which we had put up of a cerebral circulatory arrest was a bit of controversial as per Dr. Guru Prasad. Sometime in the next 2-3 weeks, we will have a discussion. I will present on cerebral circulatory arrest and a few case scenarios. I think probably these two include some 35 slides. We can have a discussion in the next few weeks. Yeah.
Definitely. Sir.
Yeah. Okay.
Yeah. Thank you,
Nothing
sir.
else. We will sign out and we'll keep in touch on the group.
Yeah, yeah. See you,
Thank
sir.
you. Thank you, Mohan. Nice to see you, Balaji, back again.
Yes, yes, sir.
Thanks, man. Yeah, cheers.
Yeah, see you.
Yeah, bye. Thank you, everyone, for joining. Yeah.